Hi, everybody. This is Dr. Daniel, and today I'll be podcasting on is there a link between vestibular migraine and Meniere's disease? The word vestibule comes from the part of the inner ear, the vestibule. In Latin, the word means an entrance hall. The vestibule is the central part of the bony labyrinth in the inner ear, situated medial to the eardrum, which is called the tympanic membrane. Behind the cochlea and in front of the three semicircular canals, it connects to the brainstem through the eighth cranial nerve at the vomit center of the brain and the brain center. In the inner ear, the semicircular canals respond to rotational movements, which are angular acceleration, and the utricle and saccule respond to changes in the position of the head with respect to gravity, and that's called linear acceleration. Definition of vertigo. Migraine has a brainstem generator in the periaqueductal gray part of the mesencephalon, near where the labyrinthine fibers from the inner ear interconnect. Migraine and vertigo have had a long, somewhat circumspect, and private relationship. Neurology textbooks for the last 50 years have listed vertigo under the long list of symptoms associated with migraine. There's a large body of literature about the subject. Vertigo is a hallucination of movement that comes from the Latin word which means to turn, and is likened to the feeling one has after spinning around a number of times and then stopping. It's what one feels on the playground after getting off of a merry-go-round. Although usually rotary in motion with the patient at the center, vertigo in its broadest definition can be expanded to be the perception of motion on the part of the patient. Thus, vertigo can be non-rotary and include a sense of linear or up and down movement. Vertigo may originate in the vestibular branch of the eighth cranial nerve, in the inner ear, where it's called peripheral, or the end organ, or it can also come in from the brain, usually in the cerebellum of the brainstem, where it's referred to as being central. Dizziness is a much less precise medical term that has multiple causes and does not localize to a specific area of the brain. Dizziness may be described by the patient as lightheaded, giddiness, near faintness, swimmy-headed, or unsteadiness. Dizziness has a large differential diagnosis that may be due to inner ear inflammation, hypoglycemia, electrolyte imbalance, low blood pressure, decreased heart output, anemia, anxiety or panic disorder, hyperventilation, medication effect, or many other causes. On close questioning, most patients can differentiate between vertigo and migraine. Complicating this discussion is the fact that the occurrence of dizziness in the general population is over 20%. However, patients who have migraine with aura have significantly more dizzy spells than non-headache patients. Dizziness is strongly associated also with functional, that is, psychiatric, medical problems. Motion sickness. Another interesting and well-known link to migraine is motion sickness, which usually comes on in childhood and improves somewhat with aging. The symptoms of motion sickness may be nausea, dizziness, vertigo, sweating, or headache. Commonly, children experience this in the back of the car when riding. It also occurs with reading in the car, particularly in amusement park rides, and especially rides that has fast circular motion, and also occurs on boats and airplanes. Most studies report that about 60% of patients with migraine have motion sickness, while only 5 to 20% of persons without migraine get motion sickness. Medical practices that specialize in migraine find that 27 to 42% of patients report episodic vertigo. About 30% of these migraineurs get vertigo when they have no headache, while many others get vertigo either just before or during the headache. Migraine with aura patients have a higher incidence of vertigo during the headache period than those who have migraine without aura. The converse of this is that practices like ENT that specialize in vertigo find 16 to 32% of their patients have migraine. Migraine without aura is headache that's one-sided, unilateral, half of head, that's throbbing or pulsating. It's moderate to severe. It causes aggravation or avoidance of routine physical activity. During the headache, the patient may have nausea or vomiting, sensitivity to light and sound. Migraine with aura adds the same description of the typical migraine attack, but it may also then have the aura symptoms. And previously used terms were classical migraine was used to be called migraine with aura. It was called hemiparasitic, hemiplegic, or aphasic migraine, which was complicated migraine. So migraine with aura should have usually a visual aura. Some persons have numbness and tingling on the face, arm, and hand of one side, and some patients may have trouble speaking during that time. Vestibular migraine is a moderate to severe vestibular symptoms lasting 5 to 72 minutes, and half of the episodes are associated with one of the following migrainous features. They have headache, or at least two of the following characteristics. It's one-sided, throbbing, moderate to severe. It's aggravated by routine physical activity. They may have sensitivity to light and sound, the visual aura. All right, and then we also have Meniere's disease, and the signs and symptoms of that include episodic rotational vertigo, attacks of off balance due to a spinning sensation, often accompanied by nausea and vomiting, tinnitus, which is a roaring, hissing, ringing sound in one ear, and a hearing loss, which may be intermittent early in the course of the disease, but usually over time causes a permanent hearing loss, and ear fullness, which may become before the start of an attack, and that's called aural, A-U-R-A-L, fullness. The duration of episodes of Meniere's syndrome disease is highly variable. About 30% of patients have episodes lasting minutes, 30% have attacks for hours, and another 30% have attacks over several days. The remaining 10% have had attacks lasting seconds only, which tend to occur repeatedly during head motion, visual stimulation, or after changes of head position. At the end of the spectrum, there are patients who may take 4 weeks to recover fully from an episode of Meniere syndrome, although the core episode rarely exceeds 72 hours. All right, migraine attacks may be induced by vestibular stimulation. Therefore, the differential diagnosis should include other vestibular disorders complicated by superimposed migraine attacks. You also have to rule out migraine and brainstem aura, which can have dizziness with it. All right, is there a link between vestibular migraine and Meniere's disease? There is a long and time-honored link dating migraine back to Meniere himself. The 2018 International Classification of Headache Disorders 3 states, overlap with Meniere's disease. Migraine is more common in patients with Meniere's disease than in healthy controls. Many patients with features of both Meniere's disease and vestibular migraine have been reported. In fact, migraine and Meniere's disease can be inherited as a symptom complex. Fluctuating hearing loss, tinnitus, and aural pressure may occur in vestibular migraine, but hearing loss does not progress to profound levels with vestibular migraine. Similarly, migraine headaches may have sensitivity to light, and even migraine aura are more common during Meniere attacks. The pathophysiological relationship between vestibular migraine and Meniere's disease remains uncertain. In the first year after onset of symptoms, differentiating between them may be challenging, since Meniere's disease can be monosymptomatic and only vestibular symptoms in the early stages of the disease. But when the criteria for Meniere's disease are met, particularly hearing loss, as documented by audiometry, Meniere's disease should be diagnosed even when the migraine symptoms occur during the vestibular attacks. Only patients who have two different types of attacks, one fulfilling criteria for vestibular migraine and the other for Meniere's disease, should be diagnosed with both disorder. And remember, Meniere's disease really doesn't have headache with it, so it helps make that easy. Related questions. Does vestibular migraine have hearing loss or ear fullness or tinnitus? Not usually. Those are specific Meniere-type symptoms which are lacking in migraine and vestibular migraine. How are these two neurological problems diagnosed? The diagnosis is usually through a history, a neurological, and otological exam. MRI scans of migraine may show T2 microvascular disease in 30-40% of patients, but as far as currently known, that doesn't mean anything. MRI scan for Meniere's patients should be normal. MRI scan could also show a tumor for a patient who has dizziness on the eighth or the hearing balance nerve. But these tumors are usually benign, and they present with deafness, but not usually vertigo or dizziness. For migraine, the neurologic exam should be normal. For Meniere's disease, there may be deafness in one ear and gait ataxia, nystagmus, or off balance if the patient is in the middle of an attack of Meniere's disease. What did Prosper Meniere think about this? Prosper Meniere lived between 1799 and 1862, and he was a French doctor who first identified that the inner ear could be the source of a condition combining vertigo, hearing loss, and tinnitus, which is now known as Meniere's disease. He thought there was a link between that syndrome, what he described as Meniere's disease, and migraine. What causes Meniere's disease? The cause is unknown, but one theory is that it comes from an abnormality in the way fluid of the inner ear is regulated, so it's called idiopathic endolymphatic hydrops. And that's a disorder of the vestibular system in the inner ear thought to stem from abnormal fluctuations in the fluid called endolymph, which fills the hearing and balance structures of the inner ear. That results in distended endolymphatic space and is referred to as endolymphatic hydrops. That is a condition that causes visible neuropathologic changes in the inner ear on exam. Usually only one ear is involved, but both ears may be affected in about 15% of patients. Meniere's disease typically starts between the ages of 20 to 50 years old, although it's been reported in nearly all age groups and affects both sexes equally. These symptoms may be only a mild nuisance or with time and repeat attacks disabling. What's the treatment for vestibular migraine? Just like any other migraine patient, person with vestibular migraine should live the migraine lifestyle. They should avoid taking butalbital or opiate narcotics for headaches, not get into medication abuse headache with over-treatment with over-the-counters. Vestibular migraine responds to the older preventive drugs for migraine like topiramate, propranolol, and amitriptyline. Whether or not it'll respond to the new migraine CGRP preventive drugs such as Aimovig, Ajovy, and Emgality is unknown. Vestibular migraine will also respond to the headache part to triptans, especially a headache that comes on with the vertigo attack. What is the treatment for Meniere's disease? The worst symptoms of an attack of Meniere's disease is the vertigo. Anti-vertigo medications such as meclizine, transderm scope patches, glycopyrrolate, and diuretics help relieve dizziness-related vertigo and shorten the attack. Some patients respond to benzodiazepine drugs such as diazepam and lorazepam. Also, anti-nausea medications like Phenergan, which is promethazine, or Zofran, ondansetron may be given, but these drugs also may cause drowsiness. Meniere's disease causes endolymphatic hydrops, which means swelling and fluid retention of the semicircular canals. So limiting dietary salt and taking diuretics or water pills such as diazide and Lasix help some people control dizziness by reducing the amount of the fluid the body retains. which may help lower fluid volume and pressure in the inner ear. There are claims that caffeine, chocolate, and alcohol aggravate vestibular migraine symptoms, so some patients avoid or limit taking them. Not smoking also may help lessen the symptoms. Cognitive behavioral therapy, a skill that helps people focus on how they interpret and react to their experiences, may help. Injections. The antibiotic gentamicin can be injected in the middle of the ear to treat vertigo, but it causes permanent hearing loss because it damages the microscopic hair cells in the inner ear. Cortisone can be injected, which also helps reduce dizziness, but doesn't have any risk of hearing loss. Vestibular rehabilitation can be done, a program including exercises for coordinating eye and head movements and stimulating the symptoms of dizziness. And that can help with balance and walking. Rare cases require surgery for Meniere's disease. Those are patients with disabling vertigo but don't respond to medication. They may be treated with surgical procedures. There's an endolymphatic shunting, which drains fluid from the ear. Vestibular neurectomy, labyrinthectomy, which is surgical removal of the labyrinth of the ear, and the eighth nerve section. And all those cause permanent deafness, but they may help the vertigo. How long has there been a known relationship of migraine and vertigo? Well, I was in medical school a medical student in the late 60s, and Merritt's textbook on neurology from that time described migraine has been found with vertigo. So I've seen that all my life. Through the years, I see several articles a year in the neurology literature describing attacks of vertigo relating to migraine, and I've seen many patients myself. Finally, vestibular migraine was integrated as an independent entity in the appendix, the International Cascade of Headache Disorders, ICHD3 beta. And this designation and definition criteria from a consensus document published by the International Headache Society and the Bharani Society together. Relationship between migraine and Meniere's disease. Migraine is a genetically inherited medical problem consisting of one-sided pounding severe headache pain associated with nausea, vomiting, sensory light and sound, and disability. Meniere syndrome is an episodic disorder consisting of attacks of vertigo, sounds in the ear, like tinnitus, ear fullness, and ear deafness. The migraine process through the relief of inflammatory neurochemicals, neurokinase, substance P, and CGRP causes neurogenic inflammation of all the sense organs, the olfactory nerve, so one may get osmophobia, the retina and the optic nerve, photophobia, the eighth nerve carrying sound and balance, sonophobia, vertigo. It's through these anatomic structures and altered neurochemical due to migraine that migraine links to Meniere syndrome. There's a long history of the literature of vestibular migraine. If you go to my web post on this same subject at www.drmigraine.com, you could read and look at some of that literature if you wish. What's the incidence of migraine and vertigo? Migraine causes more vertigo than any other condition. The incidence of migraine in the United States is 12%, while the incidence of Meniere's disease is 0.2%. About 50% of patients with Meniere's disease have migraine. Neurologic practices focus on headache, report episodic vertigo in 27 to 42% of migraineurs. What's the differential diagnosis of migrainous vertigo? This includes an ear infection, brainstem infarct, autoimmune inner ear disease, multiple sclerosis, early Meniere's disease, vertebral basilar ischemia, cerebellar tumor, and Arnold-Chiari malformation. And don't get any of this I've talked about so far mixed up with benign paroxysmal vertigo, which usually comes on with movement, is not associated with headache at all, but it just makes people dizzy. So that's the end of my dictation on this subject. God bless all you persons who've had Meniere syndrome or vestibular migraine or migraine alone. Please click on like and subscribe down there so we can follow each other. Follow me on podcasts so you can hear any future discussions I give on migraine. And God bless all you persons who have this. I'll see you again on the next talk.